Okay, so we're going to do some trigger point injections today, and actually going to talk a little bit about management of the trigger points. And so Dr. Bursa here is going to mix up some steroid. Dr. Bursa, you want to talk to us a little bit about what you're doing?
Okay. So we're going to use Solumedrol. This standard vial is 125 milligrams in 2 milliliters of fluid. So we're going to draw up about 0.6 milliliters, which is about 40 milligrams, and then dilute that with about 4.4 milliliters of 0.5% bupivacaine for a total of 5 milliliters for our injection today.
What size needle are you going to be using?
Today we're going to be using a 27 gauge 1 1/4 inch needle.
All right, good enough. All right, here's our patient. How are you? Good. So you're okay with helping create a teaching video that ends up on YouTube, and now
So
we're going to
there's
find the area that is spasm for sure, and then we're going to mark it so that when we come back to do our
Is that the
injection.
spot right there?
Yeah, that's tender today.
Yeah. And that's the same spot that I had identified previously. So what we'll do, this is, if you could feel this is very hypertonic. The muscle is really knotted up right there, and pushing on it produces pain. So that's the spot that we're looking for right there. So it's right underneath my finger. I'm just going to take my pen. I'm just going to make a little mark on you right here, okay?
Okay.
And that way we can find the same spot. It's important to pay attention to the angle. When we go in with the needle, it'll be hard to feel it in the same way. So we got to pay attention to the angle and how to get to that same trigger point in the muscle. So it's going to be about like that.
okay.
All right, so we're going to prepare this area. This isn't a sterile procedure, but I'm going to do a fairly wide prep anyway. It never hurts, and especially when you're doing any kind of injection, it's best to be on the safe side as far as that goes. So this is just some cold soap. I'm going to clean you off.
Okay.
So how are you going to inject this?
So with this injection, I know where the trigger point is. I'm just going to go straight down into the muscle fascicle and inject, draw back a little bit, and then fan out just to make sure that we cover the entire area. So I'm going to use a little of this
Pain ease.
vapor
coolant.
Yep. So this is going to be real cold on your shoulder, okay? It's just to help numb you up a little bit. So you do that right until the skin turns white. Okay. Little stick, okay?
Okay.
So we're just going to go in to about the depth that I palpated. We're going to draw back. And I think I'm right in that muscle, so
Yep, it feels like it.
I'm
Good.
going to inject about a little less than half. And I'm going to do a kind of a 4-point fan here with the remainder of it.
I think the important thing is just to make sure you don't go so deep that you do a pneumothorax or
Yeah, absolutely.
drop a lung or something like that. And
So in this particular case, we have to be very careful not to go too deep. That's why it's important to pay attention to how deep you're palpating. You doing okay?
Yep.
Almost done. How deep you're palpating. The longer you do this, the more you can get a sense of how deep your tissues are. And you just have to be real careful of that. Okay, hold on.
was that too painful, ma'am?
Oh no, it was uncomfortable, not painful.
Go ahead and move around a little bit.
So go ahead and sit up and
Let's see if did we find the right spot.
That's better. Oh yeah, I could not do that before.
yeah. So when she first came in, her range of motion was in rotation was restricted side to side. She had probably 20 to 25 degrees side to side, and only probably about 10, 15 degrees of flexion. Although she had full extension after the first facilitated positional release treatment, We got full rotational range of motion, but still had some problems with flexion, which makes sense given where her trigger point was. And now, can you take your chin all the way down to your chest?
Almost.
We couldn't get there before. So I would.
Yeah.
And how's your pain? If scale of 1 to 10.
Am I right now? None.
None.
But whenever I go down like that, it's probably 5, but not
Okay.
as bad like I told you last time. I was jerking my head back up. So.
Good. So
Do you think that she should do some stretching now, gentle stretching?
Absolutely. Gentle stretching after this can really help. All of the things that we would normally prescribe for muscle spasm can help. Heat, massage, gentle stretching all can help keep this from coming back.
And you can actually do your significant other at home can take and do the ischemic pressure. Basically, take their thumbs and find the area that hurts the most, and then just put downward pressure for about 3 minutes or so, until the muscle underneath it collapses. We say it gets ischemic, but I don't know exactly what's happening under there.
Okay.
But the muscles do relax. And I think, though, you'll find that once the soreness, anytime you've had a needle stuck in there, just like a flu shot, it's going to hurt. But once that wears off, and once the steroid does its thing, that you'll be better. If
I
not,
hope so.
yeah. If not, you can come back and blame Dr. Bursey, okay?
That's right. Yeah, I'm satisfied. We got about 50% resolution with FPR, and then about almost 100% resolution with trigger point injection. So all things considered, this has been a good treatment for you.
Well, and again, I think the issue is that patients come back sometimes after months and months of just not getting this resolved, because everybody's trying to do the traditional ways of either hitting them with narcotics or opiates or anti-inflammatory medicines, and you really got to do something aggressive on the muscle.
Absolutely.
You have to do something aggressive on that muscle.
And I think, we talk about in atrial fibrillation, AFib begets AFib, and I think to some extent it's the same with somatic dysfunction. Somatic dysfunction begets somatic dysfunction. So the longer something is in a dysfunctional position, the more likely it is to stay there and the harder it is to treat. So in this case, early treatment is a good thing.